When a patient is diagnosed with cancer, they are not fighting an external infection like a virus or bacteria. They are facing an internal breakdown of the biological rules that govern how their own cells divide and multiply. Look closely at this microscopic image. The heavily textured, spherical surface of this cell cluster is the physical result of that uncontrolled growth. The body's stop mechanisms have failed, allowing these cells to replicate at a dangerous speed. To halt this runaway replication and destroy the rogue cells, medical science relies heavily on two powerful mechanisms: chemotherapy and radiation therapy. The core difficulty in treating this disease is biological origin. Because the tumor is built from the patient's own tissue, the weapons used to dismantle it often struggle to distinguish between a healthy cell and a lethal one. Success in oncology relies almost entirely on matching the specific biological behavior of a tumor to the mechanical reach of the chosen treatment. Both of these treatments require a grueling physical toll from the patient, yet mechanically, they operate as complete opposites. This comparison matrix breaks down the four main axes of these therapies. Chemotherapy is delivered via IV or pills, reaches the entire body, and targets blood or spreading cancers. Radiation uses heavy machinery to fire targeted energy beams specifically at solid, localized tumors. The choice between them is a strategic trade-off. Oncologists must decide between deploying a chemical dragnet through the entire bloodstream or utilizing the highly constrained sniper approach of concentrated energy waves. The medical team weighs the exact location and spread of the disease to maximize the destruction of the tumor while minimizing collateral damage to healthy organs. Chemotherapy uses highly potent anti-cancer drugs designed specifically to interrupt the cellular replication cycle, forcing fast-dividing cells to self-destruct. The primary delivery mechanism is an intravenous or IV drip. By infusing the chemicals directly into a vein, the medication bypasses the digestive system and achieves immediate saturation in the blood. Certain protocols do utilize oral pills, but the underlying mechanism remains identical. The goal is to introduce a heavy, sustained chemical presence into the patient's system. This is a systemic treatment. The drugs travel through the entire vascular network, reaching nearly every organ and tissue bed to hunt down microscopic cancer cells that may have migrated away from the primary tumor. This whole-body saturation is highly effective for blood cancers like leukemia, or for metastatic cancers, tumors that have already splintered off and spread to multiple distinct sites across the body. Chemotherapy guarantees total body exposure. It is a necessary chemical burden to ensure that no hidden, migrating cancer cell escapes contact with the drug. Radiation therapy takes a completely different physical approach. It uses high-energy waves, specifically X-rays, gamma rays, or concentrated protons, to physically tear apart the DNA inside the cancer cell, permanently disabling its ability to divide. Generating these waves requires massive infrastructure, most commonly a linear accelerator. A linear accelerator is a device that uses electromagnetic waves to propel electrons to nearly the speed of light, crashing them into a metal target to produce a high-energy X-ray beam. Because of this mechanical setup, radiation is strictly a local treatment. The machine fires its energy only at the specific three-dimensional coordinates where the tumor resides. Modern oncology requires extreme precision here. The beam is calibrated down to the millimeter to sculpt the radiation dose around the tumor and spare the healthy tissue resting right next to it. Even in older clinical setups, the fundamental goal was isolation. Heavy shielding ensures the high-energy waves only penetrate the exact biological footprint of the mass, preventing whole-body exposure. This makes radiation ideal for stationary, solid tumors locked in place, particularly in the breast, lungs, or brain. It is a localized strike. It protects the rest of the body from toxicity, but offers zero protection against any rogue cells that have already entered the bloodstream and moved elsewhere. The severe side effects associated with both treatments stem from a shared mechanical limitation. They both prioritize the destruction of rapidly growing cells. Unfortunately, several healthy systems in the human body also grow rapidly by design. Hair follicles, the lining of the stomach and intestines, and the blood-producing bone marrow are consistently caught in the crossfire. This chart maps out the differing side effect profiles. Because chemotherapy has a systemic reach, its side effects land in the body-wide quadrant, causing generalized nausea, hair loss, and fatigue. Radiation sits in the targeted quadrant. Its side effects are highly localized, typically resulting in skin burns or irritation exactly where the beam passed through. For systemic patients, the collateral damage to the bone marrow poses a distinct physical threat. As blood cell production drops, the patient experiences deep exhaustion and a sharply spiked risk of secondary infections. These side effects act as a harsh biological tax paid because our current medical tools cannot perfectly isolate a malignant, fast-growing cell from a healthy one. Oncologists navigate these trade-offs by running the patient's pathology through a strict scenario match logic. This decision tree illustrates the baseline protocol. For an isolated solid mass, the logic branches to radiation therapy, prioritizing precise DNA destruction. Conversely, if the cancer is blood-based or metastasized, the logic demands the systemic dragnet of chemotherapy. The doctor's prescription is a direct, mechanical response to the physical footprint of the cancer inside the body. In many aggressive cases, these options are not mutually exclusive. Doctors frequently deploy combination therapy, utilizing multiple mechanisms simultaneously to force total eradication. A multi-pronged attack involves surgery to extract the tumor, radiation to scorch the tissue bed, and chemotherapy to sweep the bloodstream for escapees. Medical science continues to aggressively refine these mechanics. Engineers are narrowing radiation beams to sub-millimeter accuracy, while pharmacologists develop smarter chemo compounds that better identify healthy tissue. By breaking down the mechanics of systemic reach versus local precision, a seemingly chaotic medical journey becomes a calculated, strategic process designed entirely around keeping the patient alive.